I think now we can start our session, which is um, it's an extraordinary session. It's not a usual session, by the way, because I will discuss with all of you my own experience among 5 exams for Part 3 MRCOG. What are the pitfalls that most of candidates may fall in, and why sometimes candidates are insisting to fail the exam? Imagine that. Some candidates are, I can't describe this, but they are really insisting to fail. The examiners sometimes are trying to help, sometimes are trying to direct the candidate towards the right pathway in the discussion, in structured discussion, as same as in the simulated patient task. Sometimes the patient or the role player is trying also to help you, but some candidates are resistant. They don't like to follow the science and don't like to open their eyes to catch the tricks. So my session today, it's not uh, um, it's not a regular session. It's not like a presentation and I will give you some important points about how can you deal with a simulated patient task, a breaking bad news, or blah blah blah. It's not like this. I will do it like an open discussion with all of you regarding the certain points that I noticed they are the most common points to fail Part 3. On the other hand, I will describe for you those candidates who pass the exam, first shooters passing the exam, and sometimes maybe they are not, magnificent in their performance, but they know very well how can they tackle the station, okay? Because I suppose they understood successfully what is the aim beyond each station, because each station carrying some tricks. If you can catch it, you will deal with it successfully, I suppose. I would like to welcome all of you. We have 2 Asma today: Aisha, Bushra, Deepa, Tripti, Riyada, Nazia, Rahila, everyone. Thank you so much for being with me in this session. So I would like to start by the attitude of the candidate, okay? Most of candidates are going to the exam very stressed, okay? You should overcome your stress. Now, it's natural to be stressed. I believe in that. If you are not stressed in this exam, then you are not a human being, okay? It's really stressful, even for examiners. But don't let this anxiousness and stress overcome your quality of work, because most of candidates who are really stressed too much, they cannot realize many points, many important points in every station. Now, let's go for the first pitfall. The first pitfall is most of candidates cannot read the instructions and the station properly, okay? And this is a very important point, because if you cannot finish the station, reading the station in the 2 minutes, then don't get inside the cubicle and start the station unless you finish reading. You have to understand what is the aim of the station. I saw many candidates, they even cannot read the station to the end. And then once the bell is ringing, they get inside and start talking. Why? I remember very well in the last patch of the exam, I remember a Sudanese candidate. I was in this exam, in the last one of the days of the exam, I was on a labor ward prioritization station. And it's really a very long station. However, he get inside the cubicle, sat in front of me, and then he said, can I take more time to read the station? I said, yes, of course. I swear he spent extra 3 minutes reading the station. So already the rest of minutes is around 7 minutes. I said in my mind, no way he will fail this station. No time enough to cover everything in 7 minutes. I smiled and started to write my feedback because I can understand the feedback. Okay, but this candidate changed my mind. Once he started talking, he did everything in the station in a perfect way. He was able to cover all tricks, all points, logic way discussion, remembered everything. Okay, I was shocked because he's maybe the only one had 4 pass in the 4 domains with me in this day. It's very difficult to give any candidate 4 pass, by the way. So he did it. What does that means? It means you need to read the instructions very well and to do a good interpretation in your mind regarding the scenario details. If the patient is young age, a teenager, for example, this is automatically will be translated in my mind that she's at high risk of sexual transmitted diseases, sexual abuse, maybe she's an addict because she's too young. Okay, if the patient is immigrant, I may think about interpreter difficulties in language and so on. So I need to interpret the results and the scenario before start talking. And every information in the scenario carries some important messages, and you have to receive these messages and translate it properly. So don't start the station without proper reading. Then the next problem I noticed was the copy paste. I called it like this, the copy paste candidates. If I have 28 candidates per day, 26 candidates are acting similar to each other. They're starting the same, they're asking same questions by the same sequence, regardless the scenario. They are getting inside the station following their agenda, which is extremely bad mistake. Now, 90% of candidates in the exam, they are taking too much history. Okay, and this is 100% affecting their mark dramatically. In the domain of information gathering, I noticed that every candidate is getting inside and asking full history, not relevant history. The scenario is asking you to take a relevant history. So why you are asking full history? Why you are in every patient checking the mental health, the support at home? Why? Okay. Why you are asking about recreational drugs? Why? In all patients, it's not a logic thing. This attitude makes the examiner giving you borderline in information gathering, despite you asked many things, everything, but you will gain borderline. Because one of the asterisk points in information gathering domains will be asking relevant questions. Now the examiner will say, no, she or he does not able to ask relevant questions, so I will give him borderline. This is exactly what's going on in the exam. So despite you did a lot of effort, you will gain borderline. And then imagine in the same station, when you are taking full history, you will spend 6 minutes actually around taking history. So you will affect your performance in management plan, investigations, applied clinical knowledge, communication with a patient. So the whole mark will be affected. And then imagine that you will do the same performance in all simulated patient tasks in the exam. So definitely you will gain borderline maybe 8, 7, 9 times. Depends on the simulated patient tasks numbers in the exam. Imagine that. Now you are insisting to fail the exam. This is your problem, not the exam problem. Exam is very clear. Ask relevant questions, please. Okay. Does that mean by actually skipping a certain question which is not relevant to the scenario can bring us marks? 100%. Please, please trust me. Please trust me. I am behind the scene and I know what's going on exactly in the marking of each station. Now, if you ask it everything, I will give you borderline. If you ask it certain questions, very relevant, even if you missed something, not an asterisk point, I will give you pass. Okay. So exactly, Asma, like what you say. And I know I have many dear mentors and colleagues, and I respect them so much. And I'm always saying they are doing a very good job in this career and this, you know, field. But sometimes I am against them in few points. Okay, one of these points is, you know, the information gathering. Now, sometimes I may be also against them in few points. They may be against me in other points. This is very healthy thing because these differences are carrying on multiple ideas and are giving the candidates the maximum benefit. So in information gathering, don't do the same mistake of other candidates who failed the exam. Try to be very focused. Now, for example, if I asked you about a station, urogyne station, for example, a patient with a stress urinary incontinence, why people are getting inside and asking about recreational drugs? Why people are asking about family history? Why? Is the stress urinary incontinence is inherited familial disease? Yeah, just tell me about this. Is it like this? So the stress, it seems like stress urinary incontinence is not an inherited disease. So why you are asking about, you know, family history in urogyne? On the other hand, in oncology station, a patient with ovarian cancer or high risk ovarian cancer, high risk endometrial cancer, I need to ask about the family history because this is one of the cornerstone points in oncology station. I'm right? This is what's meant by relevant history. Now, is it logic to ask a patient over 60, for example, sorry? Okay, let me, I will do something very nice. Okay. Just a second, please. Now I'm back, sorry. Aisha, sir, usually domestic violence cases are hidden agenda. So should not we ask support at home to every patient, not to elderly women, of course, but to all patients in antenatal care? Now, domestic violence or abuse or all of these legal issues, you have to think in multi levels. Number one, the age of the patient, if it's less than 25 or not. Number two, if the patient is giving you clues to discover this problem or not. It's very important. This point is very important. Now, there are some points which are raising up the risk of violence, like a single woman, immigrant woman, like uh, you know, if the patient is addict or something like this, carrying the patient in the high risk group, you should ask about some important issues like domestic violence, so you can ask about support at home. But overall, this is not a regular question, okay? This is not a regular question. If there is no signs of the possibly domestic violence, like for example, patient is coming and asking about, complaining of chronic pelvic pain. You are going step by step with the patient and then asking about bowel symptoms, urinary symptoms, sexual symptoms, then asking about any discharge, any masses, did you have any blood tests before or ultrasound, PID, blah, blah, blah. And then everything is negative, negative, negative. Okay. Now, at this point, there is some risks regarding domestic violence. Okay. Then I need to change the discussion from the medical issues to legal issues, and then I can ask about support at home. You got my point? Okay. But if the patient had a chronic pelvic pain and then she gave the same symptoms of endometriosis, why don't we ask about support at home? Okay. She's an endometriosis patient. Okay. Same for mental health. Only when you get a clue. Exactly. This is what I'm always trying to tell candidates about. It's not about memorizing the pre-calls. Now, I will give you the last, in the last part of the session, I will try to give you my conclusion regarding next batches of the exam, at least for the next 2-3 years. I will give you my vision, because the policy is changed. What happened in the last 3 years will never continue like the last 3 years. The scenarios, apparently, they may be the same, but the marking sheet is definitely different, okay? And it's fashioned from this exam, I mean the last one in November, it was fashioned to test candidates who understand rather than who can memorize the answers or recalls. So don't depend on memorizing things. Try to understand, okay? It was very, very strange, for example, that I found a candidate who was asking about recreational drugs, smoking, alcohol, recreational drugs for a patient 60 years old with a suspected ovarian cancer. Why you are asking about the recreational drugs? If she's an addict, she will never reach 60 years old. You got my point? She will die earlier. So why you are asking such question? So I will give you fail in information gathering 100%. Okay. So this is very important pitfall, the information gathering. Now, what is also common pitfalls? Okay. The candidates are not understanding what each domain is looking for. Let's move step by step in this problem. Just a second, please. Yeah. Okay. Now, for example, if I would like to tell you what are the points, you know, of patient safety domain that you should cover, for example, the competent candidate should understand that in each station, I have to cover the risks, pros and cons of each treatment or investigation I will offer the patient, keep the patient dignity, including the consent and presence of chaperones with examination, for example, recognize and explains risks of patients' medical conditions, and involve sometimes risk management team, incident report, duty of candor, and all those things in cases of difficult scenarios or complicated scenarios. Now, this is the patient safety, okay? So some candidates are going to tell the patient, okay, we will give you antibiotics, prophylactic antibiotics, and we will insert the catheter in case of, for example, fistula. And I did very well job in this station. I remember the antibiotics. I offered her catheter insertion. I involved urogynecologist and urologist doctors. I did everything. I covered this station. Actually, you didn't, because when you said antibiotics, you have to rapidly give a very important point regarding the antibiotics, like possibly allergies, which kind of antibiotics I would like to give. So I suppose it's very nice to say antibiotics after exclusion of allergies and liaison with microbiologist. Now I will give you the full mark, okay? The patient had a fistula after surgery. I would like to apologize for her. I would like to apply the duty of candor, never to incriminate my medical team workers or friends or colleagues. Involve the risk management team. Incident report should be done. GP letter should be sent, and so on. So now I'm understanding how to cover the patient safety domain. Okay. If you cannot understand what are the points you would like to cover, it will be very difficult to cover these points in the exam. Am I right? So this is why I need all of you to remember which points I need to cover in each domain. Sometimes I found candidates very lost inside the station. He's trying to collect an information from east and another one from west, and to remember to take history and then start discussing investigation, and then he or she remembered another question, so come back to history and then come to management plan in a very haphazard way, which is unacceptable, because a very important part of the mark in the exam is going for systematic approach thinking. You should be systematically managing the case. So don't jump, and in the same way, don't go back again to cover missed point. You should be following the systematic logic approach in management. It's critically important. Okay. Now, what other pitfalls? Sometimes I notice this. In simulated patient tasks, 90% of candidates are not following the patient's concern. They are following their agenda. The next station is menopause or PCOS, a patient with PCOS, okay? It's a very common station and very straightforward station. Now I need to check her fertility options, and I need to tell her about the hormone imbalance and the hyperinsulinemia, the risks like endometrial cancer, type 2 diabetes, and cardiovascular problems, psychological problems, sleep apnea. This is my agenda, okay? But simply, the role player will let you talk, wasting time. And in the last minute, before the station is going to be finished, she will tell you, I'm not thinking about fertility. I'm even not have a partner. My problem is I have abnormal hair growth in a very different and, you know, very strange sites, like my face, my arms. So I need to solve this problem. Now, actually, you did a very good job regarding your agenda, but the patient is looking for another thing. You will fail the station 100%. You will at least fail in 3 out of 4 domains. Okay. So in simulated patient task, my advice, if you would like to pass, you have to start talking with the patient like, what's most bothering you? Tell me about your main concern. Okay. In your own words, can you tell me what is or why you are here today? These encouraging questions are critically important to help the candidate, I mean the role player, to tell you more and more. Active listening more than talking in simulated patient task is the key to pass the station. Believe me, all candidates in simulated patient task whom are talking too much, they fail the station. Definitely 100%. They will never pass because the major mark is going for the communication, not the knowledge. Aha. Another mistake, another very, very common pitfall. In simulated patient task, most of candidates are trying to explain and express their knowledge. They cannot believe that knowledge is about only 20% of the mark in the station. Believe me, it's only 20%. If you said everything in applied clinical knowledge and then you missed patient safety, communication, you will fail. You will gain 20% out of 100%. So you will fail easily. And this is not my expectations. This is the regulations by the college. The college said that in part 3, knowledge should never exceed 20% of the total mark. So simply, you are wasting your time. When you are trying to explain any medical condition to a patient in you know, sophisticated way, you are wasting your time and your chances. Now, for example, I had this case in the last exam, the previous exam, a patient with SUI. Candidates getting inside, they are trying to say, yeah, no, your problem, you know, we have a water bag, and the water bag is connected to outside by a water pipe, and then the water pipe is, you know, downwards, descended downwards. So there is something like a valvular action between the water pipe and water bag. What are you doing? Is this logic? Is this logic to explain all these details in 10 minutes? Now, let me ask you a question from another point of view, from the patient's point of view. Do you think that the patient is interesting to know about the water pipe and the water bag? I don't think so. I don't think so. The same way, some candidates are saying a very sarcastic thing, very sarcastic question. Your problem is called stress urinary incontinence. Do you have any idea about this? What do you think the answer is? Tell me, interact with me, friends. Do you think this question is logic? What do you think? Do you think that the candidate or the role player or the patient will answer you by, yes, of course, I know the stress urinary incontinence? It's impossible, okay? So this question is sarcastic question. It's unlogic question. This kind of discussions should not be done anymore, okay? Don't say stress urinary incontinence and then try to explain it by water bag and water pipe and so on. It's very easy to say, yeah, from the symptoms and your complaints, I think you have a situation that the bladder, you can say bladder, by the way, the bladder is descended somehow below its normal site, and that's why you lost the ability to control sometimes your urine or your water works. That's it. Simply. Overactive bladder. Do you have any idea about overactive bladder? Of course, no. Okay. The overactive bladder is, you know, the water bag walls is consisting of muscle. So this muscle is contracting to evacuate urine outside. In your condition, the muscle becoming more contracting, and then you are going to the bathroom frequently and you cannot sometimes hold yourself. It's very easy. I think you have a problem in your bladder muscle that is becoming very sensitive to any distension. That's why you have urgency and frequency. And now we will try to control this hypersensitivity muscle. That's it. So what I mean is, try to be very simple, straightforward, shortcut discussion in simulated patient task. Because overall mark is only 20% regarding the knowledge. So never in simulated patient task to go in depth with knowledge. Never. You just need to enumerate the broad lines of management and offer further appointment with the consultant. And that's it. This is your job. Never to use one option only and to give the patient one option only. It's very important to give the patient a wide variety of options and then let the patient choose the most appropriate option for her. For example, if you have a case with heavy menstrual bleeding, Mirena is the best. No, but I think I don't like to have a foreign body inside my body, doctor. Yeah, of course, but Mirena is, the NICE said, the guidelines said, everybody said that the Mirena is the best option, okay? And it will be controlling your bleeding as well as it will act like a contraception. It has a lot of benefits, so Mirena is good. You will fail. Despite your answer is great and correct, and this is truly the recommendations, but you will fail because you have to give her multiple options like tranexamic acid, Mirena, pills, progestogens. All of them are useful to control the bleeding. And then according to the pros and cons, we can choose the best one for the patient. And according to the patient wishes, always keep patient's wishes in front of your eyes. Many candidates missed this point. That's why they will lose a lot of marks in the exam, despite they are very easy to gain marks. Okay, if you are just pushing everything towards the patient and just react to the patient's actions, will be more than enough to pass the station. Everybody, you are following me well. Even if we are unable to give her all management options and we stick to answering her queries. So before going to start with the management, we need to ask her concerns. 100%. Yes, 100% Aisha. Okay. Always asking encouraging questions. Now, another problem I noticed, I would be back again to information gathering, because this is maybe the worst part of all simulated patient tasks, the worst domain ever. Information gathering. The aim is to cover maximum knowledge, I mean maximum history, relevant history in a very short time. So 99.9% of candidates are taking history like this. I will give you an example. Hello, my name is Dr. Hassan, one of the senior doctors in the clinic today. May I confirm your name and age, please? Thank you. So we will discuss your concern, and after that, we will discuss the management plan until reaching the ideal options. Is that okay for you? This is a very poor start, okay? However, let's take history. Now, tell me about your problem. Yeah, doctor, my problem is I have I can control myself. Sometimes involuntary skipping of urine may happen with me in certain situations. I'm sorry for that. So, do you have pain during micturition or urine passing urine? No. Any itching? No. Okay, so can you hold yourself until going to the bathroom? Yes, I can. Okay. And do you have any, vaginal discharge? What about your bowel? Okay. Okay. And do you have any bleeding down below? Any postcoital bleeding particularly? No. So, okay. Regarding your waterworks problem, you have any drippling? No. Yeah, any frequency going to the bathroom many times per day? No. Yeah, okay, okay. So how many times you have to wake up at night to go to the bathroom? Okay, 2 times. Yeah, that's great. Now I spend around 2 minutes asking about the complaint only points. Okay. The competent candidate may say, for example, yeah, I'm very sorry for your complaint, but do you have any other complaints regarding your waterworks you would like to share with me, like frequency, urgency, or some burning sensation or pain? No, doctor, thank you. This is only my problem. I have nothing else. Yeah, that's great. Any bowel problems? Or regarding your passage problems, like constipation or something? No. Yeah, okay. So any medical disorders that you need to take regular medications for it, or you are following your GP for any chronic diseases? What is the difference between the two types of candidates? The first one is 100% depending on closed questions. Closed questions means the answer should be by yes or no, which is not the appropriate way to ask a question. While the second candidate is following the open questions technique. Questions that giving the candidate proper space to talk, to describe, and to explain. And then the communication will be properly managed. So I suggest, for example, all candidates are, I'm so sorry for asking this question. Do you smoke or do you smoke? Alcohol drinking? No. Recreational drugs for fun? No. While the competent candidate may ask, for example, so any other social habits you would like to share with me that it may affect your general health? This question covered smoking, alcohol drinking, recreational drugs, exercise, anything related to lifestyle or social habits. This is a huge difference between, you know, the closed questions type and open questions type. I suggest that all of you should at least following 80% information gathering domain by open questions, and just keep the closed questions to formulate and finalize tiny points in history. Okay, so 80% of questions should be like open questions. You will save time, you will save effort, you will gain a lot of marks by this technique. Okay. You are really smart. Signposting necessary before social habits and asking sexually. RCOG exam preparation this October. Candidates told no signposting. What should we do? The RCOG exam preparation said no signposting in October. I am keep saying no signposting in the last 3 years, Aisha. If you are following my sessions in the last 3 years, okay, I'm telling all candidates, don't do this in your exam. Because signposting for what? Signposting for smoking or alcohol drinking, these are regular habits and social habits, and everyone is free to choose either to drink or to smoke or not. So no need for signposting. It's not a shame. Okay. For sexual problems, sexual life in UK for the patient is exactly like surgical history, medical history, sexual history. It's a part of their lives. We are, or sometimes, because of our background, the social, the religious background, the traditional backgrounds, we are dealing with sexual issues very sensitively. And this is maybe also because our practice here in maybe in Egypt, in Gulf area, in India, in Pakistan, the sexual issues are very sensitive. But actually in UK, it's not sensitive. So you can ask whatever you want, please, without signposting. It's really funny when you see a candidate say, I'm sorry, I would like to ask you a very sensitive question. Do you have a partner? Why this question is sensitive? I don't know. Is it a shame if the patient have a partner? Or if the patient has no partner, for example, is it a shame? So why it's sensitive question? Why you are signposting for something like this? You know, even in more and more rude questions, like sexually shared infections, don't signpost. Don't signpost. 100%. If your question is appropriate, no one will attack you. If I asked a patient for sexually shared infections for a reason, or it's a relevant point in the scenario, the role player will never attack you. Okay. But if you ask that question in inappropriate place, maybe the role player may be angry, and then it's very easy to absorb her angerness by saying, I'm really sorry if my question was a rude question, but it's a part of routine questionnaire to all our patients. So please accept my apology. That's it. Take it easy. Okay, take it easy. Multiple partners is a very, rude expression. Very rude expression. Okay, so how can you ask about multiple partners, okay, without asking or without mentioning multiple partners? You can ask the patient, yeah, so tell me about your partner, for example. She will say, yeah, I have a partner. So now multiple partners is out. She will say, I don't have a partner. So it means that if she is sexually active, it means that she has multiple partners. Okay, so ask about the partner, and from the answer you can realize the fact if the patient had multiple partners or not. But don't ask this question directly. If we need to take a history about STI, instead of asking you have a multiple partner, can we directly ask if you have? Yes, this is better than asking about multiple partners. You can ask directly any history of shared infections before, or any history of visiting the gum clinic for any problems. This is very, very common question. Very common. Okay. So don't signpost while there is no need for signposting. Okay. Take it easy. Again, take it easy, because UK trainees are not doing the same acts. So the examiners can easily realize whom working in UK and whom are overseas candidates. Okay. If you did the same act like overseas, I will realize it easily. Yeah. Okay. From the experience. And now we talked about most of problems. Finally, I noticed all through the 5 patches of the exam, especially in the last exam, candidates are memorizing the stations, and this is extremely dangerous thing, extremely risky, because once you read the scenario, I know it very well. Yes, and I will do 1, 2, 3, 4. Excellent. So you get inside the cubicle, start doing what you know and what you remember. You will miss any additional points to the scenario, because believe me again, there is no recall question in the exam. There is no recall question in the exam. I thought at some point that recalls are coming again exactly the same scenario. And maybe yes, but I noticed and I discovered by chance that the marking sheet is always changed. Even if the same scenario is in front of you, I will add a very tiny point in the history for the role player scenario. And if you missed asking about this point, you will lose the whole station. So maybe Aisha will attend the same station. Asma, second day, will go for the same station, but both marking sheets are different. You got my point? So it's better than memorizing everything to understand, to give yourself a space to talk, to interact, and to do many things with the role player. Don't look to the time. The time always is more than enough. 10 minutes is more than enough to cover everything. But The most important thing is to catch the clue. If you, after all this discussion, if you are still want to close your eyes and to follow what is in your mind, follow it. This is the easiest and shortest way to fail the exam. That's why our session today was, you know, the title was how to fail part 3 MRCOG. This is against all sessions, like how to pass MRCOG. No, I'm talking with you how to fail MRCOG. If you would like to close your eyes and do the same mistakes by previous candidates or previous colleagues, you will fail easily. If you would like to pass this exam, change your mind. Reformat your brain, okay? The last thing is my vision regarding February exam. I will be there as usual. May exam and November exam, this 2023 exams. I suggest strongly that exams will be more difficult. Yeah, definitely difficult. Okay. The last batch in November, I was on very difficult stations. And despite they were difficult, the marking sheet was very, very strict and difficult as well. So I think all of us need to change our minds to cope with the policy changes in the college. I think they are trying to, you know, control the success rates. This is my point of vision. Okay, so we need to do double effort, and this effort will be very easy if you are able to successfully change your mind. Aisha, sir, should we ask allergies in every case as a part of history taking, or just if indicated, and what are the indications for allergies? Now, again, there is nothing in information gathering means or in history taking is essential to be asked in all stations. Nothing. Okay. For example, if you gonna manage a case of menopause, for example, okay, so I think there is nothing related to allergies to ask about. But if you are going to discuss preoperative preparation for a case or post-operative complication or a patient with UTI, you will give antibiotics. I have to check the allergies. Blood transfusion, I have to check with the allergies and blood transfusion in certain cases when it's important to check for this. Otherwise, in between the scenario, if you would like to give any medication for the patient, you can say, like, after checking allergies and excluding allergies. For example, I would like to give antibiotics. I would like to give the patient non-steroidal anti-inflammatory after checking allergies. Okay. I would like to give the patient a hormonal treatment. Okay. Anything you can involve it in between, but it's not a fixed question. Okay. You know, this is not only my comments or even my colleagues examiners comments. Imagine that these are comments of role players. You know, sometimes candidates are asking questions, the answers are not given to the role player in their scenarios. So it means they are asking too much questions. Okay, so this is the comment of role players. So don't ask too much questions. What about Osler system? What about it? I think exam in In February, it will be all regarding the online exam, the Osler system. Most probably there is no face-to-face centers in February, and then back to May, yeah, the face-to-face centers will be back again. Osler system is very nice, very well organized system, and very easy to be used. Everything is fine with Osler. If you didn't pass through the same experience with, you know, the experience of online examination, it's a really interesting experience and very safe and perfect experience. So why global online exam is difficult? I felt it's more difficult than face-to-face. Don't say that. I attended both. So I was in global exam online. I don't know which day you were attended actually. In I was on the urinary retention distension trauma post, you know, post forceps delivery case. It was a very difficult station. I believe in that. But in face to face, I was the same way on the antenatal bipolar depression scenario and postpartum psychosis structured discussion. The marking sheet was unbelievably difficult. Okay, so it doesn't matter, is it an online exam, global exam, face-to-face in Egypt, face-to-face in UK. I don't think it's important, because number one, examiners always are trying to keep the exams balanced. Number two, the marking sheets and the passing mark is depending on days separately. So for example, if you attended the exam on Monday, 14th of November, you will be compared to all colleagues in the same day. If the day 13 was easier exam, there is no comparison between you in day 14 and people on day 13. So I don't think that there are big differences between the online or face-to-face exam. It's not a problem. But the online or face-to-face, the last exam, I noticed questions are very difficult and the evaluation is very critical. So it means that the previous attitude for Part 3 exam should be changed to a new vision, new format to cope with the new era of the exam. No hands-on stations. I don't think so. No, no. This November exam, all questions were difficult on last day of exam. 2 OT list, labor word prioritization, all difficult scenarios. Believe me, in the Monday exam online, in Egypt Center, the 2 days I was on labor word prioritization and psychosis. Both were very difficult. So all through the scenario, this is what I'm talking about. This is why I conducted this session today, to tell you the pitfalls and to tell you the fact that exam is going to be more and more difficult because the evaluation and the scenarios will be changed somehow. So we need to prepare ourselves from now to overcome these tricks. If we can understand the tricks, we can overcome them easily. If I will start from this week for preparation and start practice of stations, is it enough to enter February exam? Is it good time? You need 1 month. You need 1 month, 6 weeks to cover everything and to understand the exam and to be prepared and ready. However, it depends on how much hours every day you can dedicate for the study. Okay, if you are too much busy, I think you need 2 to 3 months, for example, preparation. If you can save 2 to 3 hours daily, I think you can cover everything in 1.5 to 2 months maximally. Okay, this is my suggestions. But of course, this question, no one can answer this question except you. You know your capabilities, your time management, your time schedule, and your ability to study better than anyone else. Okay. Any other questions? If you revise this session again and write out all my important points I told you about and start from now to apply these points in your practice, trust me, you will find this exam very easy and interesting exam. You will find it like a play, okay? But if you are insisting to keep this exam very difficult, stressful, stressing situation for you, it will be a nightmare. So take the easy pathway and remember our tricks. We still have more tricks, but of course, we will meet again in also free sessions to talk more and more about each domain separately and how can we cover each domain in an easy way to put a very good background for all of you, especially in difficult scenarios. Thank you so much, Asma. Thank you, everyone. Amy, how should we prepare for structural discussion stations? For me, it's difficult. Believe me, for me, it's more difficult as well. Structured discussions are difficult for everyone. Okay, even for the examiner. Okay, so yes, smile, because it's really difficult because it covers many things. It covers many things, many aspects of evaluation, as well as the in simulated patient task, you have the opportunity to ask the patient and waiting for any information helping you to manage. But in structured discussion, this option is absent. So I know it's difficult, and most probably, if you are all interested in this, we can go for a separate session, okay, a 1-hour rapid session, okay, to know how can we tackle structured discussions and what are the back doors to pass in structured discussions. This is very interesting session. So keep following Mid-Exam Expert. I will announce for this session very soon, maybe the next week, and we will spend 1 hour dealing with structured discussion tips and tricks. Just keep following us, and thank you so much for being with me today. I hope I gave all of you important knowledge, and thank you so much. Keep studying, keep working, and keep your dream in front of your eyes. This is the last step in your journey, and all of you are able to do it successfully. See you soon. Have a nice night. Bye-bye.